Start. Okay. Good afternoon. Uh, First of all, I would like to thank Luis for his very kind invitation. I always feel like home here, and I always enjoy coming here and enjoy the meeting. Now I'm going to start with presenting our experience on ACoA aneurysms, treatment with flow diverters. With the sidewall aneurysms, which have integrated vessel to the sac, the flow remodeling concept caused a paradigm shift, and it inspired us to use this treatment in the bifurcation aneurysms as well. We showed this example everywhere, how we ended up with this treatment. When you change the direction, a bifurcation aneurysm may act like a sidewall aneurysm when you compare this image with the PCOM aneurysm, with the PCOM coming off. So as the experience built up in complex MCA bifurcation aneurysms, we realized that the flow diversion induced flow remodeling, and it brings simplicity and efficacy to the endovascular treatment if we do the proper management pharmacologically, conceptually, and technically, so that it would be very straightforward to treat such a big MCA aneurysm with a simple flow diverter placement. We first started to apply this treatment in technically challenging cases. It is possible to treat this aneurysm with other things, but it is tricky because this vessel comes off with a difficult angle. But because we have a flow diverter at hand, it makes it very straightforward, very simple treatment, very effective. This one is pipeline. This is pipe. I mean, we do a pipeline. Not exclusively, but our experience started with pipeline. Or this one, for example, but it also taught us at MCA the flow remodeling concept. What do I mean by that? When there's a vessel coming off from the aneurysm, because of the flow demand, despite that it changed its shape and got smaller because the flow is needed to those vessels, it remodels the bifurcation, the origin of the vessel. So we shouldn't call this as a aneurysm remnant. It is needed to keep the flow into those branches. So this is not a aneurysm remnant as we used to call with other techniques. So we ended up having a new classification for flow diverter treatment. It is important, especially for the aneurysms which have an integrated vessel coming off the sac. If there is complete occlusion of the sac, if the branch is patent with its original size, then we call class 1A. So the entire class 1A, B, C, whichever, is equivalent to Ramura class 1, depending on the size of the branch coming off the aneurysm sac or sac. Getting smaller, 1B, the branch occluded 1C. And we also defined a class 5 for flow remodeling. This is the basically new concept that if the branch is continuing from the sac, then it may not show entire sac occlusion as we were used to, because the branch is continuing through that sac. It may either take the shape, different shape within the sac, or it may show some enlargement to provide the flow. And if it is stable, then we call it as a flow remodeling. But if we see for the first control, then we don't know if it's going to be stable or if it continues to grow, then it is neck remnant at the first angio. So class 5 is basically either having a different course of the branch or a enlargement at the origin of the branch, which stays stable at least for 2 control angios or at least for a year time. So we also learned that when there's a branch coming off the sac, that's to say at bifurcations, it takes longer time than the sidewall aneurysms. So we shouldn't get frustrated with the early controls saying that, okay, the technique failed. No, it doesn't fail. Preoperative, 6 months later, it took a new shape. The small sac below is occluded, got smaller. However, it took 1 year to have the aneurysm got occluded. It got occluded with the branch itself as well, filling in a retrograde fashion. This case is from Jivan. Actually, it shows an extreme example that with the flow diverter, it took like 3.5 years to have the remodeling completed. And finally, at 4 years' time, there is complete occlusion of the aneurysm. So with the bifurcations, we shouldn't hurry to call it the technique got failed. Yeah, I mean, extreme meaning, yeah, beautiful, beautiful. That's why I'm actually showing this. Well, we'll ask Jivan at what time.
For a year, and then a year after we put him under aspirin, right? Chlorospin 300 milligrams.
At MCA, by the way, just in the brackets, we continue anti-aggregation, active anti-aggregation. I don't call double anti-aggregation because now our routine is prasugrel, and we give prasugrel as the single drug, but we apply the so-called effective anti-aggregation for at least 1 year at bifurcations, that's to say at MCA bifurcations especially. So we never stop anti-aggregation before 1 year, and then lifelong aspirin. And the more we see the examples, the more enthusiastic we got. We published the results at MCA. First in our own series, then combined with Limoges group. Very happy with the MCA results. And then after we are satisfied with the results, we started to apply it to the cases where we can do other techniques as well. Not necessarily to very straightforward, very simple bifurcation aneurysms, but for example, this one can easily be treated by Y stenting. The angles are, straightforward, 90-degree angle shouldn't be a problem, but why bother yourself doing Y stenting when you put a flow diverter, very easy, and have this 1 year control result? So why take any risk to put 2 stents, do Y stenting plus coiling? So anyhow, this is our history with MCA bifurcations, and it also applies to the ACOM region as well. The target of simplicity is the same for ACOMs. In this talk, I only included the ACOM, which means the real ACOMs plus A1, A2 junction aneurysms, not the A1s or A2 and distal. So only ACoMs and the A1, A2 junctions. For example, this one, it is not a straightforward case for other techniques, but very straightforward for, to place a flow diverter at the neck into the non-dependent, straighter, easier A2 trunk from A2 to A1. And this is how it looked like at 6-month control. We are not seeing the contralateral A2 filling at 6 months, but look how it looked like on the other side. The A2, the contralateral A2 is not filling in the preoperative. It's a very hypoplastic A1, but at 6 months, it was enlarged due to the flow demand, and the ACoM aneurysm is gone, and both ACAs are filling very nicely. Another example, multiple small blebs. We treat this patient not in the very acute phase, had a previous bleeding, and we put the flow diverter in the straighter A2, and this is how it looked like at 1-year control. The entire anatomy is remodeled. The blisters are gone. And this is the 1-year control on the same patient. When both A2s are at the same ease of reachability, then we prefer the aneurysm neck where it is more oriented to. For example, in this one, ipsilateral, and the A1 on that, the contralateral is not filling, aplastic. At 6-month control, the aneurysm is gone, and the contralateral A1 is filling very nicely, despite that it was not at the beginning, preoperatively. Another aneurysm at the junction of A1, A2. Ipsilateral from A2 to A1 pipeline device, and 1-year control. Aneurysm is gone, and each ACAs are filling very nicely from the ipsilateral injection. Another example, A1, A2 junction, 2 blebs. There's A1 on the other side to start with. There is fenestration, and the pipeline device it was, and this was how it looked like at 6 months. This time, it was a real ACoM aneurysm. Both A1, A2s are similar in dimension. This patient had previous subdural and subarachnoid bleeding, had an operation, but they could not clip the ACoM aneurysm, only wrapped. And because the angle was too tight, we decided to put the flow diverter from the contralateral A2 to from 1 A2 to the contralateral A1, because it's straightforward in terms of the orientation. And the 6 months control. This is the left A1, right A2, right A1, left A2. The right A1 and left A2 got smaller in size because of the jailing. However, filling the entire territory is filling very nicely. And 2-year CT angio control on that patient. The patient is asymptomatic, doing very good. This was a regrowth aneurysm after the simple coiling after a subarachnoid hemorrhage. And for the remnant, we put the flow diverter at the neck. At the beginning of the treatment, the right A1 was hypoplastic during the initial treatment, as you see here. However, at 2 years control, you see a very nice filling of both ACAs ipsilaterally, and the aneurysm is gone. So previously treated and regrown aneurysms, it's a good alternative for retreatment, good option. Another example, right A1 is not filling at the beginning. The entire ACOM is actually dysplastic, and we choose the larger trunk and let the smaller one remodel if both branches are difficult. This is how the post-operative placement, angiography showing the placement of the device from left A2 to left A1. And this is the 1 year control. So the anatomy is remodeled, the sag is gone. And the right A1, which was not filling before, started to fill. So because of the flow demand, the anatomy remodels. As we gained confidence, for example, with this one, we may have treated with other techniques as well, but Vista Baby was available, sorry. So we thought it's a good option for this patient with all those below tortuosities. This lady has other aneurysms that we treated before, but we didn't at those times because, you know, it was, although it's a little bit irregular, but we thought it may wait because of the anatomy. And with the Vista Baby, we felt more comfortable. And this is the 9-month control on that patient. This patient we treated with Jivan during the WLNC Barcelona this year. It's a true ACOM aneurysm. Both A1s are filling symmetrically. Then double flow diverters can be placed either in parallel alignment or in X alignment, as in this one, because it allows two flow diverters opening up at simultaneously. In this one, because the angles are not easy to place parallel flow diverters, we prefer to do X flow diverter placement. We opened up together simultaneously both Vista Babies, and left A2, right A1 is filling from the right side injection, and right A2, left A1 filling from the left side. We are waiting for the control of this one. Good flow diverter stent opposition is very important, especially if there's a branch coming off, a critical branch, so that there would not be a thromboembolic complication and that branch keeps its patency. The subcallosal branch was taking off, and with the proper medication, the branch stays open while the aneurysm is getting occluded. This is only 1 month control MRA and 6-month control CT angiography on that patient. The aneurysm is gone, that branch is patent, And this is the 1-year control DSA on that patient. This was a regrown aneurysm after clipping. There is a one on the other side as well. And for that one, we placed a flow diverter ipsilaterally, and see there is that so-called remnant at 6-month control. But when you do 3D, so we always do 3D angiography for these patients so that we can appreciate if a branch is continuing from the sac, which is the case in this particular patient. And the left A2 is filling. Although there is filling of the left A2, possibly the flow is not good enough so that there is still flow demand from here as well. And this is the 1.5-year control, 18-month control. See the continuation of the vessel from the sac. So we do not call this at this point remnant, but it is the remodeling. So it's class 5 occlusion as according to our classification. So the aneurysm is gone and there is that remodeling of the origin of the branch. Another example for the remodeling. So at 6 months, because there is flow demand, the aneurysm got smaller, but not totally occluded. So at this point, it's a so-called neck remnant, class 2 occlusion, according to Raimon or our classification. But when we see being stable, and it is continuing with the branch, it is no more class 2, but it is remodeling. It is class 5 at this point. So in our series, this does not include the case that was treated during WLNC this year because it was in another institution, so it was not our primary case. This does not include that one. Our treatments were all with pipeline except for one Fred Jr. and one Vista baby. Overall, 31 aneurysms due to multi-segmental disease tandem aneurysms. We have complications in 2 patients, one ischemic event with no clinical consequence, and one asymptomatic, very limited subarachnoid hemorrhage in the post-op routine Dyna CT. Both does not have any clinical consequence. We don't have mortality or permanent morbidity in this series. We have follow-up in 25 patients. So follow-up rate is 93.5. From 6 months to 5 years, all aneurysms got occluded either class 1 or 5, except for one. There happened to be device shortening in the control that the aneurysm, it was a retreatment. It was not covering the entire neck due to shortening of the device. So actually, it was not the failure of the flow of diversion, but failure of our treatment. No aneurysm regrowth or rupture during this period. In this series, except for 2 patients, all patients were pre-medicated with prasugrel or ticagrelor. So only in 2 patients, clopidogrel was used. I just, before I finish, I want to show 2 papers, one from Johns Hopkins, published in 2017. These are the largest series entirely dedicated to this group of aneurysms. I did not take into account short series or entire ACA series so that I can give a good correlation. In that first paper, 41 patients, they had one major stroke, no death in the series. They have 83% follow-up available, and O'Kelly-Marotta classification, they had 85% occlusion according to last follow-up. So they present an all pipeline in this particular series. So they report very satisfactory results. And very recent paper from Jack and his group reporting on 30 patients, Plavix and aspirin till 2015, and then they switched to ticagrelor, different kinds of devices. Despite that, they are reporting a complication rate of 26.7%, permanent deficit only in one patient, 3.3%, no death. And the adequate occlusion rate is 87% in this series. So for the ACoA aneurysms, flow diversion is an option. Of course, we need to, so as a conclusion and to summarize some important issues, it is to simplify the treatment. Anti-aggregation should be done using new generation, more reliable drugs, not with clopidogrel. If you are to use clopidogrel, then please do not do this treatment at such locations like ACOM or MCA. Follow-up results should be interpreted with a different understanding. You have to keep in mind the flow of remodeling concept. And also, we need to remember that it may take longer time than we were used to with the sidewall aneurysms. Some useful tips: we oversize 1/4 millimeter or 1/2 millimeter, and we choose the straighter, non-dependent or larger branch to place our flow diverter. Flow position is very important. If you are not happy with it, I would recommend to do a balloon angioplasty so that it would oppose well to avoid thromboembolic complications and for the patency of the jailed branch. And the device shortening should always be considered during the length selection, because at this anatomy, you may have shortening and you may end up seeing your device more proximal or more distal than you initially placed. I thank you for your attention after this very good meal. And if there are any questions or comments, you're very welcome.
No cases of endoling from, I saw A1 getting bigger on one side, but no case of, when we start doing this with pipeline, we're worried about that you jail the ACoM and the aneurysm would fill from the back door. You haven't seen any case like that?
No, but possibly because in many of our cases, there was the hypoplasia of the other side, and there was one real, so to say, real ACoM aneurysm that we put from one contralateral to the A2 to A1. So it was crossing all the way the neck at the ACoM. It may be the reason. In another true ACoM aneurysm, we did H-shaped, like 2 ipsilateral. It was the only double flow diverter case. That might be the reason. Yes.
Thank you. it's incredible your presentation. Do you think at the moment the coiling of the aneurysm is necessary or only flow diverter?
No, no, it is not the message. I mean, the message is not treating all the ACoA aneurysms using flow diverters. As you have seen many examples here. They are not straightforward cases for flow diverters. At some point, we may say, we may replace the conventional technique with. My message is flow diverter is a very good option for ACoM region in selected patients, but because the conventional technique, we know the long term, we know what we are going to have. So if it is suitable for a regular treatment, so to say regular, then why not do a classical conventional treatment and then do flow diverter if there is any recurrence. It is not like, okay, from now on, I'm gonna treat all my ACoA aneurysms with flow diverters. No, it is not the message at this point.
But do you think it's not easy to put one baby sick?
Yeah, I mean, that's what I.
Or to the coil, balloon, whatever.
Yeah.
Surely it's not easy to put one small.
Yeah, I mean, for selected anatomy, yes, why not? Because it's 17 microcatheter. That's why, I showed an example that we could have treated with stent-assisted coiling. Why I say stent-assisted? Because it was small, it was wide neck, so we may have needed stent to coil, or even simple coiling could have been done for that patient. But with Baby Vista 17 microcatheter, it is not any different than putting regular stent. So instead of bothering yourself with jailing a microcatheter within that tiny vessel, putting a coil, or trying to clip with the open surgery with that shallow aneurysm, put a Vista baby and you are done. Why not? Yeah.
Yeah, I actually had the same question as Luis, but another point is, have you used it also for ruptured ones?
Not in the very acute phase. In some blisters we used, but usually patients came to us as a referral center, so they are out of the acute phase at least for a week or so. So in that scenario, yes, we did use flow diverters in acute phase. No, luckily no, but possibly because we were not in the very acute phase. Say it again. Depending on the orientation, domain neck ratio, for example, we do web treatment as well. We like to do web treatment. So a regular sac with, putting one web device, then why not bother yourself with anti-aggregation? You just put an intrasaccular device and you're done. Or, we take into account all kinds of options, but this is just to say that flow diverter is a good option as well. Okay.
So I didn't want to tell anything, but just Luis gave me the mic. So I just want to tell you, congratulations. I fully agree with you with every point.
Okay, thank you for
A new device.
thank you for the support then.